Well, I apologize for any confusion on the title. It was changed several months ago, but it didn't get worked through the system, unfortunately. So this is actually, apologize for the misleading advertising, the title of my presentation, Acquired TTP, New Therapeutic Options, and Their Optimal Utilizations. I do also want to thank the organizers for the invitation to come speak today, and what I've always found to be a very fascinating and interesting topic. So many of you have obviously seen this before and understand that ADAMTS13, the protease, is really central to the pathophysiology of acquired TTP as well as congenital TTP. A very nice cartoon or figure from Dr. Sadler's work I've always liked because I think it very simply shows the function of the ADAMTS13 protease to cleave these ultra-large multimers of our factor as they're secreted, leaving physiologic multimers circulating. In contrast, where there's a congenital deficiency or an acquired deficiency through an antibody-mediated inhibition or clearance, you lack the function of cleaving the protease. You get the spontaneous formation of microthrombi and platelet von Willebrand factor aggregates. It's not required for the diagnosis. It remains a clinical diagnosis, but it certainly confirms the clinical diagnosis and really identifies and narrows down a subtype, a true phenotype that you can use for study, both in therapeutic as well as long-term studies. You want to get a pretreatment sample, but it's certainly not essential, and work from our group at Nan Wu recently published shows that even after 3 plasma exchange procedures, nearly 80% of patients still have evidence of severe ADAMTS13 deficiency. So if you didn't get it at presentation, there's still time to check it. It still may be beneficial and helpful. So again, nothing new for this crowd. The diagnosis of TTP, it's a clinical diagnosis comprised of thrombocytopenia, fragmented cells in the peripheral blood, with no other clinical explanation for the findings. And again, as we've talked about, as I mentioned, the deficiency of the ADAMTS13 protease really serves to confirm, not diagnostic, but confirms the clinical diagnosis. You're all well aware of the treatment, but I feel obliged to at least mention them. The plasma exchange therapy, which both removes inhibitors as well as adds back functional protease. We use normalization of the hematologic parameters, the platelet count and the LDH, to define clinical responses, but it really has to be remembered that these are surrogate markers for the formation of microthrombi, which really is the disease. The disease is not a low platelet count, but it's a microthrombotic disease, and these are the easiest and reproducible and objective surrogates that we have. You also want to see at least stabilization, if not improvement, in the end organ injury. Adjuvant immune suppressive therapy is also given, most commonly with corticosteroids, but other immune suppressants are given, including Rituximab that I'll talk about briefly later in the presentation. So it may or may not surprise you to tell you that there are a lot of similarities to humans, mice, and rats, at least in terms of TTP, in that deficient ADAMTS13 activity alone is not sufficient by itself to lead to an acute TTP episode. Certainly a strong risk factor, but if you look in both animal models and human data, you get a good example of this. In ADAMTS13 deficient mice, they do not spontaneously develop the thrombocytopenia or the TMA findings, but rather require something else, this second hit, if you will, whether it's shigatoxin, collagen epinephrine, or recombinant von Willebrand factor to initiate or trigger, if you will, an acute TTP or TMA episode. A very interesting presentation this morning from Johanna Kramer really brought this point out with the congenital TTP, that these patients may be diagnosed later in life, and usually at the time of a triggering factor, which could be infection, pregnancy, or something else. So again, even patients who may be deficient for many years need that sort of second hit, if you will. If we look at acquired TTP, you see a similar phenomenon. Recovery of the ADAMTS13 protease activity is not required to achieve remission. I'll try to convince you later on in the presentation from some of our data as well as others that deficient activity in remission is a significant risk factor for relapse. But relapse is not uniform in patients with ADAMTS13 deficiency, severely deficient. So we have a couple patients in our cohort that are followed without treatment, clinically, at least as we can determine, doing well. It's also important to have uniform terminology, and I think over the last 10 to 12 years we've had this, and I would credit Drs. George and Lemley for coining and defining these terms, which really have been helpful, so we're all talking about the same terms. Exacerbations of TTP, as well as relapse, are used commonly in clinical studies. to determine outcomes. Exacerbation being defined as a recurrent thrombocytopenia, defined as the need to restart plasma exchange in the first 30 days after stopping the plasma exchange. Relapse of TTP being defined as a recurrence greater than 30 days after the last plasma exchange procedure. The clinical utility really is to differentiate what is a continuation of a previous episode from a new and distinct episode. And although it may appear a bit arbitrary, I think there's some data that I can show you that these actually are distinct clinical events that may actually have distinct risk factors for their occurrence. Again, we'll talk a little bit later in just a couple of slides about severely deficient ADAMTS13 activity and what I believe is an increased risk for relapse. But what about exacerbation? Is ADAMTS13 activity related to the risk for exacerbation? Answers might not quite so clear, I would tell you. And these are some data that we subsequently published but presented at the ISTH in Boston back in 2009. And what we did in this study was look at the pre-treatment ADAMTS13 biomarkers and inhibitors, as well as at the time of response, which is the first week after plasma exchange has been stopped. You can see they're comparable populations in terms of the pre-treatment ADAMTS13 activity. If you look at the time of response, so this is in the first week after plasma exchange has been stopped, the ADAMTS13 activity is significantly lower and still severely deficient in those that suffered an exacerbation. However, if you do a covariate analysis, which we did and account for race and sex, primarily African American race, the effect is no longer present. There's no significant difference after accounting for race as a covariant. I would also sort of describe to you some of the work we're going to present in poster form later tonight, looking at a prospective study comparing corticosteroids to cyclosporin and using exacerbation rate as the short-term outcome measure. 4 patients suffered exacerbations, and actually 2 of the 4 had essentially normal, above 50% ADAMTS13 activity. So I think it's not so clear that the ADAMTS13 activity is a risk factor for exacerbation. But again, as I've mentioned, the risk of relapse in remission and measurements of the ADAMTS13 activity, and this is sort of the first work published in this domain from Flora Pavandi and her group. They looked at 109 patient samples that were, again, studied in remission greater than 30 days after their last plasma exchange procedure, but prior to clinical signs or symptoms of relapse. The majority of patients had 1 sample obtained. If you look at the median ADAMTS13 activity, I apologize, it's a bit difficult to see, but in the patients that didn't have a recurrence or a relapse, the median was 41% compared to 12% in those patients that did subsequently suffer a recurrence of TTP. They went a bit further and actually came up with the odds ratio and calculated this for ADAMTS13 deficiency in remission at 2.9, increases to 3.6 when they have the deficiency as well as the demonstrable presence of an inhibitor. About the same time, we did a similar analysis. The main difference between our work, again, these are plasma samples obtained in remission from patients with a previous diagnosis of TTP that was confirmed by ADAMTS13 deficiency at the time of their presentation. We studied 157 serial samples from 24 patients, so a large number of samples from individual patients. Some followed for as many as 5 years. The way the modeling was done, it evaluates the risk of relapse in the subsequent 3 months. So patients are followed in our registry every 3 months for the most part. So the modeling was done via logistic regression analysis to determine the relationship of the ADAMTS13 activity to clinical relapse in the following 3 months. And if you take all of the data collectively together, you certainly see as the ADAMTS13 activity decreases, there's a higher probability of relapse in the following 3 months, but really not so great, 5 to 10%, which doesn't seem so significant. But if you break this down for age, the younger you are, the greater the risk for recurrence in the subsequent 3 months, suggesting that age may also contribute to the risk of relapse, with patients 20 to 30 years of age having a risk of 40 to 50% in the subsequent 3 months, which certainly is significant. So although I do believe the ADAMTS13 measurements in remission are certainly important, as Sarah already mentioned, you have to be careful with these measurements. As a rule, variability is the case when you measure these serially in follow-up. And if we take 13 patients from our previous study, 13 of the patients who had a continuous remission for at least a year, and look at their ADAMTS13 biomarkers over time, and you certainly see this variability, widely fluctuating levels in all 13, with just under half of patients at one time dropping below 10% and rising back on their own without clinical relapse. And again, these were 13 patients who did not suffer a relapse. Similar data that you heard from Sarah as well, showing in the Oklahoma registry, 52 asymptomatic patients with at least 3 measurements in remission. 38% had 1 to 8 ADAMTS13 activities. 38% of the patients who had these measured had 1 to 8 levels of the ADAMTS13 activity that were less than 10%, with 75% spontaneously recovering to greater than 10%. So I do believe it's a risk factor, but like many clinical measurements, I don't believe you can rely exactly on one measurement. And we'll talk about that in an upcoming slide as we discuss our approach to using serial measurements and following the trend rather than one individual measurement. Rituximab, I think many of you are familiar with, both in malignant hematology as well as in ITP and TTP. It is a monoclonal anti-CD20 antibody that targets B lymphocytes. The mechanism of action has always been proposed to be the suppression of the production of the anti-ADAMTS13 antibodies, with responses occurring really within 2 weeks. If you look at some of the data that's been published by Marie Scully on behalf of the UK group, you certainly see this in terms of the ADAMTS13 activity in the solid line and the dashed line showing the inhibitor levels. You do see a rise in the ADAMTS13 activity, which corresponds to a decline in the inhibitor concentration over time, with the majority of patients doing so within the first 2 weeks. There actually have been some data also published suggesting that rituximab may actually modify the T cell compartment, although these are certainly preliminary. But it certainly suggests that you can use the ADAMTS13 activity as a reasonable biomarker to follow the efficacy of prior immune suppressive therapy, especially with rituximab. So if you take the ADAMTS13 deficiency in remission and the risk for relapse and are able to model it, you can certainly make an argument for the role of prophylactic immune suppressive therapy. It's a bit of a controversial topic, but certainly one that we should be talking about. Data presented from Westwood et al., again from the UK group, looked at 21 TTP episodes from 15 patients who received prophylactic rituximab administration in remission. 17 of the 21 patients had ADAMTS13 activity that was less than 5%. 4 of 21 were between 6 and 14%. So nearly all the patients, 16 of the 17, normalized the ADAMTS13 activity within 3 months, with one patient relapsing after 70 months, the follow-up ranging 1 to 89 months. So certainly at least provocative data suggesting the efficacy of rituximab in preventing a future relapse of TTP. If we look at sort of data that followed this, published by he et al. On behalf of the French TMA Reference Center, and the study they performed a retrospective study in patients with TTP and severely deficient ADAMTS13 activity during follow-up. They studied 30 patients who received prophylactic rituximab administration compared to 18 subjects who either the physicians chose not to administer rituximab or it was not available at the time. If we look at the prophylactic rituximab group, the group that was treated with rituximab, they had a median of 0.57 relapses per year prior to their treatment with rituximab, which decreased to a median of 0 per year. Essentially, only 3 of 30 patients relapsed during follow-up. If you compare this to historical controls that weren't treated, relapse rate of 0.5 relapses per year, very consistent with the pre-rituximab data in the other treated cohort. If you look at the relapse-free survival in these two cohorts of patients, you do see a significant difference in terms of relapse, clinical relapse, in the patients that were treated with rituximab preemptively or prophylactically compared to those that weren't. So what are the arguments for or against? And I think it's very difficult to come down very strongly on either side given the available data. I think you can't argue with the efficacy. It seems to be effective. It seems to at least delay, if not prevent, future relapses of TTP. overall, except for infusion-related events, there really have not been reported significant or major side effects, and for the most part, quite tolerable. You have to certainly understand when you talk about the data that these are not placebo-controlled data, and there are patients, rarer than some, that will not relapse with severely deficient activity during follow-up. The duration of follow-up in the Rituximab-treated patients is also a bit shorter than the non-treated or the historical controls as well. Another argument against it certainly could be made that the expense of treatment and who really needs it. Are we treating people who really weren't destined to relapse, but we spent that money and exposed them to the risk? And certainly there's also the concern, even though I believe the ADAMTS13 biomarker is an important biomarker, you can be overly focused on this and run into over-treatment, retreatment, exposing patients to side effects that were never intended based on a number and not the patient. But I think a very interesting point was raised by Adam Sucher in a commentary he wrote in Blood recently, really talking about the patient perspective and the freedom, the feeling of freedom for relapse that you can get from this. And he proposes that his patients, and I would say mine as well, are very much willing to take what they feel is a small risk for what might be a psychological benefit of that feeling of being free from the risk of relapse. So that's not going to drive this discussion, but I think it certainly has to be considered as you counsel patients regarding this. If we talk about Rituximab for prophylactic treatment, you certainly have to discuss the role of splenectomy, and it's a reasonable thought for prevention of long-term relapse and future relapse of TTP. And I present some data here published by Caplacizumab in 2005, looking at 24 patients who underwent splenectomy for relapse TTP, history of previous relapses. This was a retrospective study again, but these were consecutively admitted patients to referral centers in the Netherlands from 1982 to 2002. The median number of pre-splenectomy relapses, which is 2, which is an important number that we'll get back to in a couple of slides coming up. Follow-up mean of 111 months with a range of 9 to 230 months. Relapses post-splenectomy occurred in approximately 25% of patients, occurring at a roughly median of 15 months, and a calculated relapse rate that decreased from 0.74 relapses per patient year down to 0.1. So again, suggesting the efficacy of this approach. This is a Kaplan-Meier curve showing similar to the Rituximab data, relapse-free survival. I would caution you that this is also including 9 patients who were treated for refractory TTP with splenectomy. But I think you can at least make the argument that these are comparable data in terms of relapse-free survival, looking at least at the 24 patients who were treated for relapsing disease, with very long follow-up, I would also mention. Similarly, a meta-analysis has been performed, and again, it's hard to rely on meta-analyses as much as it is hard to rely on non-controlled studies or uncontrolled studies. But collectively, you have 87 patients looking at the role of splenectomy for relapses of TTP and prevention, with, I would tell you, comparable numbers, 15 of 87 or 17%. The follow-up in many of the studies is actually quite long as well, giving us quite a good view at its efficacy. So certainly I think data worth discussing and considering, and I think worthy of prospective study in the future as we can collectively get together to study these issues. So how do you approach all these data collectively in the absence of a clear answer? What do you do? Our approach has been to look at patients with ADAMTS13 activity that is deficient, at least 2 measurements that are deficient consecutively, before we will strongly consider the immune suppressive therapy, either Rituximab or cyclosporin. We also only do this with patients with 2 prior episodes, so their initial episode and 1 recurrent event. In the absence of an absolute and definitive answer, we think our approach will identify patients who are at risk for relapse, but also who demonstrate, if you will, the phenotype of a relapsing disease, someone who's already demonstrated to do it, and therefore we would argue that in this cohort of patients, the risk of immune suppressive therapy the benefit outweighs the risk for immune suppressive therapy in this cohort of patients who are deficient and have demonstrated this risk of relapse. I'll move on to some of the targeted therapies, which I think are very fascinating and interesting, and you'll hear more about during this meeting. The first targeted therapy was what's called ARC-1779, a nucleic acid macromolecule, small molecule that binds to the A1 domain of von Willebrand factor, inhibiting its prothrombotic function, inhibiting the formation of microthrombi. This was given as a continuous infusion, this endpoint being shorter course of plasma exchange, quicker recovery of the platelet count, with hopefully, as we'll talk about in an upcoming slide, decreased end organ complications. Unfortunately, due to financial reasons, only 9 patients were enrolled, 7 study drug, 2 placebo, so you really can't make any comment on the efficacy, but certainly the safety was there. There were no significant bleeding events, and what's shown in this graphic is the relative von Willebrand factor functional activity correlated with drug concentration. So with rising concentrations, you can see suppression of the von Willebrand factor functional activity in these cohorts of patients, which returns after drug concentration is there, suggesting the clinical efficacy of this molecule. The follow-up molecule for this is ALX0081, or it's now called Caplacizumab. And the phase 2 study, the Titan study, has just been completed and was reported at ASH in 2014. A similar molecule, an antibody, an anti-von Willebrand factor, an antibody that binds to the A1 domain, again blocking the prothrombotic function, blocking the interaction of von Willebrand factor to platelets, theoretically blocking the formation of microthrombotic disease. Single-blinded study compared to placebo. They received an IV injection, but in contrast to the ARC-1779, the dosing is given subcutaneously. What's also very important about these data is it was given 30 days after the last plasma exchange procedure. So it covers that time period of exacerbation, helping to assess, if you will, the protective effect of the molecules. 75 subjects were enrolled, 36 to the Caplacizumab, 39 to placebo. There certainly was a 39% reduction in the time to a normal platelet count, so a less dependence on plasma exchange to achieve that. But what I think is actually more interesting is the decrease in the exacerbation, or this 30-day failure rate after plasma exchange was stopped. 28% in the placebo-treated group compared to 8% in the Caplacizumab-treated group. This number, the 30%, being roughly the exacerbation rate that most of us would agree with from historical data and historical controls. I think demonstrating what is the protective effect, if you will, of the Caplacizumab. After the drug dosing is stopped, you see an increase in relapse events, now occurring greater than 30 days from their last plasma exchange procedure. But I would also tell you the majority of these patients also had severely deficient ADAMTS13 activity. So what sometimes could be viewed incorrectly as a failure of the medication actually is a demonstration that the medication has a protective effect, but the disease still needs to be treated. The ADAMTS13 inhibitor, the protease deficiency, still needs to be addressed. And we don't do that, you get a recurrence of the disease, if you will, and what is roughly that 30% recurrence rate that we've all talked about. So I think very interesting data, worth further study. I mentioned before this platelet count is a surrogate biomarker for the efficacy for the formation of the microthrombotic disease. So with a normalization of the platelet count, the presumption is we're no longer forming microthrombotic disease. The real question, though, is when you get a more rapid remission, are you going to impact long-term complications? So is a shorter time with microthrombi being formed beneficial and long-term? There will be some data presented tomorrow as a late-breaking abstract, Wednesday at 2:30 in the oral session. But this is an issue that's going to be studied in greater detail in the upcoming planned phase 3 study, which is certainly the most important issue. It's nice to see a platelet count recover quicker, but are you having an impact in these patients in terms of the incidence as well as the severity of these end organ complications that we're all becoming too familiar with? There's also some work that should be discussed talking about recombinant ADAMTS13, actually. And there's some very interesting presentations this morning in mouse models of acquired TTP. But the prophylactic administration of recombinant ADAMTS13 activity was shown to be protective in a mouse model, a congenital mouse model of TTP. But also in vitro studies that were performed that showed a linear relationship between the inhibitor titer and the recombinant ADAMTS13 concentration necessary to reconstitute the protease activity. And some of the work shown this morning was a mouse model of acquired TTP, which really demonstrated the same thing, suggesting, although on the surface that recombinant ADAMTS13 may be more important for congenital TTP. There may actually be a role for it in acquired TTP, the antibody-mediated TTP. And to talk briefly about another very ingenious approach to therapy and some work done in the lab of Dr. Long Zhang, capitalizing on some of the work he's done as well as others that have documented and shown that the majority of TTP patients have IgG autoantibodies that will bind the spacer domain, a domain that's critical for the recognition and proteolysis of von Willebrand factor. So their group, Gian et al., created 24 ADAMTS13 variants, 2 which were found to have an increased specificity against the VWF73, so increased actually functional activity, but more resistant inhibition by the ADAMTS13 autoantibodies via reduced binding, their ability to bind. So it's certainly a very interesting approach to modifying recombinant ADAMTS13 to increase the efficacy and not have to deal with the issue of overcoming an inhibitor titer. So I think a lot of the slides and data I've shown really are a good example of the basic science research really translating into improved diagnosis and treatment of patients with TTP, as well as helping us to understand and predict clinical events to allow us to know really who to treat in certain clinical scenarios and who not to treat. We're starting to understand the risk of relapse better. We're not quite there yet, but I think we're getting closer. And really, what's most encouraging are the novel therapies that are now being in clinical study in TTP, really trying to decrease the dependence on plasma-based therapies, but more importantly, to prevent some of these long-term complications that we're all too familiar with in the clinic. So with that, I'll stop and thank you for your attention.